of the drill stop because I had some questions concerning the drill stop. Now, when I first developed this drill stop, at that time I was using Strawman drills. And Strawman drills are very similar to blueskybio drills as far as the size is concerned. But as you notice here, it says 8, 10, 11 and a half, 13. So I have two sets of these. The first set is 8, 10, 12, 14, which is the indication for Strawman tissue level. And I use those with blueskybio. And then when blueskybio came out with a bulb level implant, they had 11 and a half and 13. That's the internal hex, which is different. Also, the first set, in order to secure the drill stop to the drill, you needed to have a set screw. Because on a 2.2 millimeter drill, if this is a 2.2 millimeter drill and you slide the drill stop on it, it would slide off. So you needed to have a screw to tighten it. The reason you need a screw to tighten it is because the shank of the drill up here that goes into the handpiece is the same size as the drill, cutting flutes. But then when you go to the 2.8 drill, the next size up, the cutting flutes are slightly larger. So when you slide the stop on, you don't need to fasten it with the set screw. A lot of people said, well, I don't like to use that set screw because you got to tighten it and untighten it and all that. And if the set screw is so small because the diameter of this is so small, if you lose the screw during surgery or something, it falls on the floor. You know, like plus the screw was a pain to use. So there's a company that came out with a new set of drills, and that company is Hartzell. So I've teamed up with them. So personally, I use Hartzell drills with all my different implants. When I use the whether it be the bluesky or the tissue level or bone level, I use these drills. And the nice thing is the drill itself, they developed so the drill, the stop is one size of the sleeve fits all the different diameters, okay? So you can use the same one on a 2.0, 2.2, 2.5 or whatever because it's got this raised area right here. So it slides down and it stops there. So it slides down on each one so the same stop fits on all the drills. And you just slide it on, it stops, you put the drill in your handpiece, it's set, and so it can't go anywhere. So it's foolproof, it just can't go anywhere at all. And so with my first generation of stop, you had to have the set screw to anchor it in or it would fall off on the 2.2 drill. And again, the reason I like to use the stop is because when I'm drilling, then I don't have to look for the lines. Because with the water spray and the blood and all that, only thing you have to do is you just have to focus on the long axis of the drill. And then I think your osteotomies and whether or not you want to use them with a surgical guide or without a surgical guide, because when you drill down and you're focusing on the long axis, the only thing, it prevents you from going any deeper than what you set the osteotomy. So with this set, you don't have to have a set screw. With the other, my initial set, you needed to. And all of them are the same size, so you can make your surgical guides a certain diameter, and they are all interchangeable. So someone had asked me about that, and I just wanted to show you that video. Okay, get Okay, so in determining success for anterior placement of implants or for aesthetic implants, it's very important that you have a precise position of the platform and orientation of the implant. And you must have bone tissue around the implant, and you must have the presence of papilla afterwards. So, I mean, those are the things that we're after. So, in order to achieve this result, you must follow the rule. You cannot make your own rule, because like the sign, you can't fool Mother Nature. Mother Nature knows the dimensions have to be there. Biologic width, like we were discussing earlier, is approximately 2 millimeters. So you must maintain the proper space between the implant and the teeth. And that space is about 1 to 1.5 millimeters. And you must maintain the proper space between the implants, which is about 3 millimeters. And if you want to have a papilla present, you have to have the contact of your crown or prosthetics about within 5 millimeters or less than 5 millimeters from the crest of your bone. If you have that present, then you're going to get a papilla form most of the time. Now, again, what you want to do is you want to position the implant in an optimal three-dimensional position. So it's very important that you maintain this distance from the implant to the adjacent tooth. And these x-rays, I mean, these photos are two-dimensional. But in order to maintain this peak of bone right here, you have to have this distance. Because after you place that implant, you get a saucerization around this implant, and you get some bone loss around the neck of this implant, even with the collar that's there. Now, some implant systems, such as Ankylos, perhaps market and say that they preserve crestal bone. But I don't know if that aspect is significantly, it is significant. Sure, it would be nice to have more bone, but with some of the small amount of bone loss that you have, in my opinion, over the years, it's not presented to me a clinical problem. You may look on the x-ray and say, oh, see that little loss of bone, but it's not a clinical problem over the years. So you have to make sure that when the implant is positioned, you are in this zone that's not too far lingual, but far enough, and not too close mesial-distally to the adjacent teeth. And if you follow that rule, you're probably going to end up with a decent aesthetic result, 95% of the time. So with the tissue level implant, you want the platform of the implant about 2 to 3 millimeters apical to the CEJ of the adjacent tooth. And so here's your CEJ of the adjacent tooth. So you want your implant platform apical to that. And you want it apical to that so you have enough room to create your profile for your tooth. If you don't put your implant deep enough, you're not going to be able to create the emergence profile, and you may end up with a shorter appearance tooth than what you want, or you may end up showing a little bit of the collar. So you have to have a transition zone. So when you build your prosthesis, you have this room to create the profile. And that it's critical that you be with this platform far enough away from the adjacent tooth, 1 millimeter to 1.5 millimeters. And then also in your prosthesis, you have to make sure your contact point is probably less than 5 millimeters from the crest of the bone. Now that last video I showed you, with that immediate placement, we screwed that implant. You could see that there was a little bit of a black triangle of space, but that was day one. But I would show you the X-ray, but my computer is not, functioning for some reason, so I'm having to use Johnny's and got my presentation on a jump drive. But that space, that tissue filled in, and it normally will fill in a 6-month period of time if your contact to the crest of the bone is less than 5 millimeters. If it's greater than 5 millimeters, you're not going to get a fill of that papilla. So, taking that into consideration, you must determine where your CEJ is going to come out, where it's going to be positioned, and then you position the implant accordingly. And this is what I mean about this distance from the contact point to the crest of the bone. If it's less than 5 millimeters, and Dennis Tarnow from NYU University did a lot of research, and there's a lot of papers in the literature to support all this, that shows that that papilla is going to fill in over time if you have that dimension present. So not only the distance of the placement of the platform from the implant to the tooth, you also have that distance from implant to implant. And if this implant encroaches less than 3 millimeters apart, you're going to cause a little bit of bone loss. With a little bit of bone loss, you're going to get the tissue follow that, and then you're going to end up with those unsightly spaces between the teeth. So the main issue a lot of people have with this 1.8 millimeter collar is being afraid that they're not going to position that collar properly, and you're going to have that tissue shrinkage, and you're going to show metal, and which would be unsightly, especially if they have a higher smile line. But in the bone level implants, the bone level implants have to be further up apically than from the CEJ than the tissue level implant. And the reason is because if you look closely here, this implant here, this dimension there, basically 4.1 millimeters. This is 4.1 millimeters, but it's got the flare to it. So that's why it doesn't have to be as deep, and you're still going to have enough room to create your emergence profile. So if someone says, well, which do you like to use, the tissue level or the bone level? I like to use tissue level because it allows me to control the emergence better. It supports the tissue. When you have but I do place a lot of these bone level, smaller diameter, but you have to if you don't have enough room. Like when you're talking about, say, a central incisor where the space is wider, you can use those, but to use that tissue level implant in a lateral incisor region is difficult because you don't have enough room, because you have to take in consideration, here's 4.8 plus, say, 1.5 millimeters on each side is 3 millimeters, so 4.8 plus 3, that's 7.8 millimeters. So you need a much wider. That width of the implant is too great for that space. So when the implant is placed, you want to try to get it in a 3-dimensional position, and this kind of explains the green area is where the safety zone is, and the red area is an area that you don't want to be encroaching with the implant in that area. And sometimes in the anterior region, this is difficult to do. So again, you want to have 1.5 millimeters, maybe 2 millimeters between adjacent teeth in order to place your implant. So taking that in consideration, you just can't, if you go to place an implant and your distance is narrower and you don't have a variety of implants in your drawer, pick out and use, you may be in trouble. You can't just use one implant in all situations. You must have a numerous assortment of implants, or at least at your availability, so you must do your planning before you start. So, and even when you place your implant, you don't want to have to you don't place your implant too far to the lingual, because if you place it too far to the lingual, then when you do your restoration, in order to prosthetically make it, you may have to try to lap the ridge in order to get the prosthesis out far enough. And if you do that, then you're going to have a cleanliness problem. And at the same time, especially with the tissue level implants, if you place that implant too far to the labial, you're going to encroach on that bone, and then it's going to be, you may get a little bit of loss associated with it, recession of the tissue, and then have a difficult time with your aesthetics. So always what you want to do is you want to know where you want the tooth to exit out of the gum. Where you want the tooth to exit out of your gum line through your wax up or your diagnosis, and then place the implant 2 to 3 millimeters apical to that position. So the key is you got to maintain this peak of bone. If you encroach and get too close to the adjacent tooth, you're going to cause loss. With that bone loss, you're going to get shrinkage. Then you're not going to have an aesthetic result. So again, it's critical that you maintain that peak of bone. You maintain that peak of bone by having the proper distance. So this was a case where we were preparing, taking off old crowns. We took off these old crowns, and when I took off the old crowns here to re-prepare these, this tooth here had recurrent decay up underneath the crown. We took it off. We could not do a root canal on that tooth because the root was totally calcified. So we had no choice but to extract the tooth. So we extracted the tooth and placed an immediate implant. Well, we extracted the tooth and placed an immediate implant. And if you look here, you'll see this area here. You can see how we lost bone right here compared to here. So if you were to place this implant too far in this direction, and then you lose that bone with the shrinkage, you're going to get an exposure of that metal collar, that polished collar, and that's what you don't want to have. So this tissue here is a result of what you can form with a immediate placement single stage implant, even with the polished collar, with these larger diameter healing collars, or sulcus formers, if you want to call it a sulcus former. So again, if all of your cases turn out like this, that's going to be great. There's the margin of your crown. The margin of the crown is about 1.5 millimeters, 2 millimeters below the gingiva. So you can screw in a solid abutment here, fabricate your crown, and be in good shape. Now, if this were further apical, then you may wish to make a custom abutment to lift up the crown margin so you could clean the cement. So this is about 3 or 4 year follow up on this particular case with that tissue level abutment. So the vertical position here allowed you to create a crown that blends in with the adjacent teeth. So in order to get those types of results, it's critical that the platform of the implant be in the correct position. That you maintain this peak of bone, and you'll maintain that peak of bone if you have that distance from the implant to the adjacent tooth. So this was a 1-year follow-up on a case that I have done, and I'm going to show this whole case a little bit later in the presentation. But this is the implant here, and we did get just a little bit of recession of the gingiva, but overall it's a good aesthetic result, and this doesn't look like it's caved in at all. And this is a year follow-up. So going back, you got to make sure you get the platform of the implant at the correct position, and you have to maintain your proper spacing. And it's important that you be 3 millimeters away from each implant and 1.5 millimeters to 2 millimeters from an adjacent tooth. And if you do that, then you will maintain these peaks of bone that you'll be able to create aesthetic results. So those dimensions are critical, that you maintain those dimensions. So here's a case that there's an implant crown here, and here's an implant crown. And we're going to show you that case and its total later on. But the end result is you've got tissue in a nice papilla here, but it is really difficult to create the same height of papilla between an implant and a natural tooth. It's easier to do than between two implants, even when you maintain your spaces. So in this particular case, with these two, those implants are even a narrower diameter because I didn't have enough room to get wider implants. So your success depends upon using your diagnostic wax up and have the laboratory involved or communicate to the laboratory what you plan on doing, work your plan, and then also, I think with the use of surgical guides, you can create that 3-dimensional placement. So it's like a puzzle we're trying to put together. And the parts of that puzzle are the patient, the implant surgeon, the restorative dentist, and the laboratory technician. Now for me, I'm both the implant dentist, and as most of you, you're the implant dentist and you're the restorative dentist both. So you have more control over the end result. So if you are not doing the restorations, some of these small little details are not as important to you as if you were having to do the restorations yourself. Some of the surgeons who only place the implants, sometimes there's complaints that they don't place the implant in a position that allows you to do restoratively what you wish to do. So this is my son, and I like to play tennis. That's my passion. That's what I love to do. But in playing tennis, I know that if I want to win, my partner back here should be probably better than me. So it's so important that you have teamwork. You have to have teamwork with your laboratory. You have to have teamwork with your surgeon if you're not placing it, and if you're only doing the restoration. But teamwork is extremely important. So my favorite tennis player is Roger Federer. And I was sad to see him not win this year, but he almost beat Djokovic in the U.S. Open. But anyway, they say in tennis that you're only as good as your second serve. Well, in implant dentistry, you're only as good as the surgeon that places it and your laboratory technician. I don't care, you can have a perfect placement. If you've got a laboratory that doesn't do the prosthesis well, it's not going to turn out well. So you can take a mediocre placement with an excellent technician and make it look good. But if you give a good placement and to an excellent technician, you can make it look like that illusion of reality that we're all trying to achieve. So really, implantology is prosthetically driven. You've got to provide either for yourself, if you're doing it, or if a surgeon, if you're not doing it, the proper position where that implant needs to be placed. And it's critical that you understand the number and the size of the implants to prosthetically create the type of occlusion that you wish and need to accomplish. So, prosthetically driven means prosthetically you have to know where you want to end up and then place the implants accordingly. And many times, you must have good open communication with your patients. You must understand what their desire is. With some patients, I don't think you're going to meet their desire. That some people have an unrealistic expectation of what you possibly can do. Many times they have thin biotype tissue, they have severe bone loss, and they want to look like a perfect Hollywood smile. But it's impossible to do that. So, but most of the time, patients want a nice smile, and they want the implant to function and be able to chew their food with. And I can't stress this enough, that a patient with a combination of a high lip line and a thin biotype is extremely difficult. And these particular patients with a high lip line and a thin biotype, they are difficult to please aesthetically. So there's this analysis that you can go through determining the location of the smile line and the type of gingiva they have and what kind of dimensions you have, the assessment of their occlusion, whether or not you have enough space, whether you're going to have to make it a screw retained prosthesis or whether or not you can make it a cement retained prosthesis. So there's a lot of evaluation. It's just not, okay, there's a space, I'm going to stick in an implant and then I'm going to restore it. Especially when you get involved up in the areas in the aesthetic zone. But again, most of these people want to be able to bite into an apple, and they want to be able to eat an ear corn. So if we're going to be successful, we have to plan properly. So in this slide, this situation here, you have to understand that if you have a vertical loss of bone, to my knowledge, there's no way to grow that bone back up to create that type of situation over there. And if you have a situation such as this on this side, and they have a high smile line, you're going to have teeth that look rather large. Or whether or not you have a superb technician that can add pink porcelain, it's just very difficult to solve those aesthetic situations with the combination of bone loss, a high smile line. It is extremely difficult. So I showed this case a little bit earlier, but this is a situation where you're going to do your diagnostic wax up. You're going to determine where you want to place your implants, and then you're going to establish make your surgical guide. And this is a different way that initially I made my surgical guide. You're going to use that guide to place your implants, and then you're going to end up with the aesthetic result that you want. Now, if you were to get a little bit of shrinkage, and if perhaps you got a little bit of exposure of the metal collar that's there, if you did, and if someone smiles as wide as they can, this is all you see, and you inform your patient of that there is that possibility on the front end. If you do end up with that, they're usually not concerned because you've discussed it with them, you've explained it to them. But if you have one of these types of patients that says, no, I don't want that, then you're going to have to really pay close attention to all the things that you need to be doing in order to create this aesthetic result. So this would be a case that this is where we started, here, and this was being held in with denture adhesive. So denture adhesive would hold this in, we pull that off, and this is what she has. So there was some issues as far as the occlusal clearance that we had. And there was short teeth here. There was some limited space available. She wanted to show more teeth when she smiled and all that, so we extracted these teeth and we trimmed and removed some bone. And everybody sometimes wants to preserve bone, but there are situations where you have to take bone away in order to get this aesthetic result. So an assessment of this amount of room that you have here and where you want your prosthesis going in. So we extracted the teeth, we trimmed the bone, and we let it all heal up. She wore a temporary flipper in that period of time. Then we went back in and then we made our surgical guide. We created these channels for our trajectory of where we want to place our implants. That shows the surgical guide is allowing me to go in the direction I want to go. And then this was at the first day of surgery. Everything healed up, and by trimming some bone and creating enough room, we're able to get the implant position and have some excess tissue. So I would always rather take away some in the prosthetic tissue development as opposed to not having it there to begin with. So this shows that surgical guide went back in, the implants, everything had healed. There's a straight, solid abutment there, there's a straight, solid abutment there, and there's one here that a little bit has been trimmed off. But the cost to do this was reduced significantly because you don't have to go through the expense of custom abutments. So this shows the first set of temporaries that we made. And many times in these aesthetic cases, you have to go through this tissue modeling, and you have to go through one set, maybe sometimes two sets of temporaries in order to end up with the result that you wish. That's why I think that these bigger cases, although they're gratifying to do, and many times you don't plan that you're going to have to do so much, and you end up not making the same remuneration, the same amount of money than if you were just doing simple, straightforward cases. You have to build that into your fee. So by using the temporaries and molding the tissue and trimming some of the tissue because we had excess tissue, we were able to go from the size of this tooth here to this one. And in the process of also, mold something that somewhat looks like a papilla. So there were our temporaries, and the temporaries had to be made and adjusted and all that to create the aesthetic look that you want, and the amount of smile, the amount of tooth that's being showed by the patient when they smile. So, I apologize, I got a couple blurry slides in here, but the end result is such that it does kind of create that illusion of reality, but it just doesn't happen. It takes a lot of time, it takes a lot of planning in order for this to occur. And again, this case I showed you a little bit earlier. I'm just going to go through it again because it's in sequence. In the aesthetic zone, many times you have to extract the teeth, you have to wear something temporary, especially when you have multiple teeth, because you must let the tissue mature before you go back in and place the implant. So you must have a system. And that system, I think, for your success is to start with the end in mind, plan your work your plan, and always have a backup or a plan B. Because many times, what you think is going to happen, sometimes for whatever reason, it doesn't happen. So, by having your removable flipper, by making your determination of where you want to place your implants, going forth and putting the implants in there with the use of a surgical guide in a three-dimensional position will allow you to create the final prosthesis that you wish. So, by extracting the teeth and letting everything heal up, we're able to go back in and place the implant. And in the process of extracting the teeth, instead of just extracting the teeth and just putting the flipper in, if you add enough material on the underside when you extract the teeth and then put your flipper in, you're able to create some papilla here. So that when you go back in and place your implants, it does, even with the surgical guide, give you a little bit of a reference as to where you want to place those implants. So we decided to put one there and one right there. So we've got our surgical guide, and we go back in. This is the surgical guide in place, the tissue's flapped open. This shows just starting with a round burr, but this guide constricts and allows me to go into a trajectory that when I go in, I'll be confined in the bony housing. Now, someone asked, well, what happens if you have to change your angle sometime? Well, there are situations where you start with your guide. This is where you want to place your implant. And let's say, for instance, the ridge was a little bit narrow. We may start with this guide, take this guide out, still go in that same position, and maybe use those little expanding screws. It's hard to use those expanding screws through the guide. So sometimes the guide can be used on all the drilling sequence. Sometimes you only use it for the first one. Sometimes you can only perhaps use it for the starting and for your reference. So this is the same guide that we're probably here at probably a 2.8 drill down to depth, because I think this ridge was a little bit narrow when I did this case and I didn't do any expansion with it. So the implants were placed in, allowed to heal. Then I made screwed in solid abutments, and then I used acrylic and made some temporaries. So I made some temporaries to try to develop some sense of papilla here. Sometimes we take a little electrosurge or a laser and scoop that out, or sometimes take a little round burr and take a little tissue out to try to create that illusion of reality. So once you take your temporaries off, take an impression and fabricate your final prosthesis. So this is her final prosthesis. So sometimes, you know, we get involved with some even more complex cases. And this is a situation where all these teeth have periodontal disease. So the end result for her was to do, over a period of time, we were going to do the upper arch and the lower arch both. And economics dictated that I only do the maxillary first, then we did the mandibular later. So here's where we started. She has an extremely deep bite, spaces, periodontal disease, bone loss in that, and again, this is where we finished. Now, you might say, well, wait a minute, where's the papilla, where's the pink gingiva, where's all that? But in this particular case, this was probably done about 8-9 years ago. I didn't have the same laboratory technician I got now, but this is her full grin of smile line, and she was extremely comfortable with this. But still, to create this support here, built out all of porcelain, can be challenging. So she had This was all one piece. Again, here I had to use some custom abutments here. It's all one piece, and she did not want to go through the process of doing sinus lifts. I probably would have liked to have gone back in here and done some sinus lifts and made this even larger, but for her, she was happy and content. So it all depends upon how much of the tooth is visible at full smile as to what you can end up. And this is her final prosthesis. So, I mean, this probably took a year to a year and a half maybe to do this economically. So we did the upper first, we left the lower teeth in, then we did matched the lower up to the upper. So actually at this stage she was in her temporaries in the top, and she had her teeth on the lower. So we left 2 bicuspids in to maintain a vertical and centric position. We extracted all the other teeth. At that time I didn't place the implants in, and I made her a temporary. She wore that temporary, and then in that period of time I ended up finishing the top, but I'm still dealing with the lower. I left the temporaries in, left the 2 teeth in, then I went back in, placed all of the implants on the lower, allowed all of those to integrate. Then I made her temporaries on the lower, extracted the 2 remaining teeth, and completed it. But, you know, situations like, and there's a lot of different ways that you can do it depending upon what your philosophy is as far as your occlusion, and depending upon the time frameworks that the patient has for you. There's a lot of different ways to do it. I don't think there's a right or a wrong way, but you know, to end up with a full set of teeth on the lower, I mean, it takes a long period of time, and you know, it's an expensive process, do the whole process. But she basically has second bicuspid occlusion, and she is extremely comfortable. Sure, there's a little bit of metal platform showing here, but that's so far below the level of her smile that, you know, she's not concerned about it. So when you can't place the implant in the proper axis because of the bone, I guess there's 2 ways you could do it. You could augment the bone to try to create an ideal environment, or you could place the implant in the direction that the bone allows you to do it, and then make your compensation by using custom abutments. And usually custom abutments are needed in the anterior region more so than in the posterior region. Basically, you can raise the cement line with a custom abutment, because if you make a cement retained crown, it's difficult to get in subgingival, clean that cement off, and if you don't clean that cement off, you're likely to cause some bone loss or a sepsis around the implant. But with those custom abutments, you have to take an impression, implant level impression, and there's different ways that you can either then, if you don't want to raise the cement line with the custom abutment, you could make a screw retained crown, or you could do simply a cement retained crown. And this is the UCLA type of abutment that I use. It's got the Sonata in here, and there's a waxing sleeve, and I use Straumann custom abutments on Blue Sky implants because these are cast gold, or not titanium. I like the cast gold better than the titanium. In case I want to add opaque to it, it's more difficult to add opaque, if not impossible, to the titanium. So this would show a case where I have 2 implants. One implant is significantly deeper than the other implant. So this one I could get by with just a solid abutment, but this one here, I was reluctant to make a solid abutment and be able to get in it. Plus my axis was off a little bit, so I elected to, in this situation, make a custom abutment. And this shows the custom abutment. The axis had to be changed. Even with this solid abutment here, we had to dust this off a little bit, but in order to get the crown so it was thick enough so we didn't have a hot spot to show through in the metal and the porcelain. But many times what we do is they have the zirconia abutments out now, but I don't like to use zirconia and screw it in against the metal. I would rather have metal on metal as far as the interface between the abutment and the implant. So what I do is I take the gold custom abutments. Let me get back here. I take the metal and I have opaque added onto the metal. So I have the opaque added onto the metal, screw that in, and then we can make your Empress or any of the all porcelain ceramic crowns. Sometimes in situations where maybe you have thin tissue, what we'll do is take and add a porcelain collar, and this goes a collar of porcelain in here to help prevent the bleed through of the grayness. So that goes subgingival, so you don't see any gray here. In this particular case, we still made a porcelain fused to metal crown, and we didn't get any of the gray that was showing through. So sometimes in multiple units, you can take and have your porcelain baked onto the custom abutment. And when you bake those onto the custom abutment, you mask any of the bleeding through. Depending upon what type of bridge work, you could make a all ceramic bridge, or you could make a porcelain fused to metal bridge. And so the end result is you've got the vertical position of the implant such that you can create this emergence profile and create the situation where it looks like there's teeth growing out of the gums. And if you don't have enough running room for your prosthesis, this is difficult to do. So I'm going to touch a little bit now on the media placement. I think it's a situation that you can't use all the time, and I just showed you a couple cases where you definitely would not want to use an immediate placement. I think immediate placement is good if you can, when you place your implant, you can get enough stability, and that stability is maintained during the healing phase. I think you have to do it on a case selection basis, and I think you have to follow a proper protocol for it. And I think that your skill set to be able to do this increases with time. I mean, you don't want to have the very first implant that you place as a immediate placement, but with time, anyone's skill set can get to the level where they can place implants immediately. And I think you have to have, a suitable implant system. And with a suitable implant system, such as Blue Sky, you should be able to use them in immediate cases. So we're all at a different level of that learning curve when we start this, and it takes a period of time to increase your skills. And no matter where you are on that learning curve, as long as you're progressing and improving your skills, that's what's most important. You can't start at the top. There's a certain learning curve that you have to go through in order to get to the top. And really, I don't think, even in all the years I've been doing it, I'm not up here at all. And I don't know if I'm ever going to get up there, because there's constantly room for improvement all the time. So you don't want to walk around with your head in the clouds. You want to know where you're going. And if you know where you're going to start with, you're going to be much better off. So when I started placing implants and got more involved in immediate placement, one of the problems that I had was kind of visually understanding where my platform was going to be through that whole process, and how that, using these tissue level implants, how you were able to get your platform to end up where you wanted to get it up, where you had enough tissue, where you had enough running room, It's definitely more complicated in immediate placement than in delayed placement and a healed ridge. And so I came up with this idea of making this 2.2 pin, and it's threaded, and at these different levels, the threads are not there. So you can see where you are when you use it by just counting where you don't have the threads. So it's 6, 8, 10, 12, 14, and each one of these collars is exactly the same size as the collar that's on the Blue Sky implant. It's 1.8 millimeters, and there's a 6.5, a standard 4.8, and a narrow neck at 3.2. So with the use of that collar, it allowed me to position those implants in the vertical position that would allow me to create this same type of emergence that needs to be established in immediate placement. So this would be a case that is an immediate placement, and in order to position that collar in immediate cases is more challenging, and there is a learning curve than in a delayed ridge. So this would be another example of an immediate placement. And if you looked closely at that, one advantage that you have in a situation like this is not a thin biotype. This is a thick biotype of tissue. And thick tissue is much easier to work with than thin tissue. But I think most of the Asian population is more thin than thick. So by putting that implant in and putting that implant at the correct vertical position gives you this amount of running room to create this prosthesis. This is the very first implant that I ever placed immediately. And this has probably been in over 15 years. And you can see right here just a little bit of scarring there, because when I placed that I did pull back the tissue a little bit so I could evaluate the bone. And again, this is another implant, immediate placement here. So I think it's possible with immediate placement to get the implants in a position where you can create static restorations and they're stable over time. Even though it is a higher risk procedure, I think that for some people to say, I don't want to do it, I think that's okay if you don't want to do immediate placement. I think if you develop the skills to do the immediate placement, your patients will be happier and your implant side of your practice grows because you're able to do the procedures in a faster period of time, and that just people refer more patients to you, satisfy people because you did it much faster than the long-term approach where you have to extract a tooth, wait 6 months, place it, wait another 3 months before you make your prosthesis. So here would be a case that this particular girl was in a car accident, and she was my, I came to my office as a dental hygienist, and she worked in my office, and really, I didn't know that she had this temporary, I mean, she had a flipper in, and then she wanted me to place some implants, so so we're going to place an implant here, we're going to place an implant here, and these are going to be immediate placement. So this is the flipper that she had, and if you count the number of teeth, she's got an extra tooth in there. So whoever made this temporary didn't quite use the proper size teeth. So we took an impression of that, and from that impression, tried to determine, we knew we were going to put the implant here, and we knew we were going to put the implant here. But we kind of gave us an idea of what size of teeth that could fit in these spaces. So again, we extracted the tooth and placed the implant. Now I know that you say that this Polly's collar is totally submerged. Now, it looks like it is in this particular photo, but when you extract a tooth, you've got a hole, socket, and then you're placing your implant. And you're not filling that whole socket up. There's space there. And you must maintain space because you've got to be at least 2 millimeters to the lingual, because through the healing process, you're going to lose bone on the inside of the socket, you're going to lose a bundle bone, and it's going to move back. So all in the immediate placements, you have to have at least 2 millimeters of space. And it's hard for you to see that 2 millimeters of space in this particular photo, but it is there. So that's the implant in place. And here is our final prosthesis. And these were solid abutments that were screwed in. And if you want to be critical, you can see this little dark area here. You can kind of see the metal coming through a little bit. Because there's an implant in each position there. And this is, when I took this particular case, it was 3 years post-operatively, but now it's probably going on about 5 years, 6 years. So the immediate placement can be predictable, and it can significantly decrease the amount of time that you have start to finish in your cases. One thing that you have to be cautious of is you can't, again, in these maxillas that have a really large convexity here, you just cannot follow the path of the socket. You've got to go to the lingual, and when you go to the lingual, that means you can't start drilling here. You got to start drilling back here. Because you got to start drilling back here, and then you got to end up, because this whole implant has to be back over there. Because if you leave it like that, you're going to have a failure. So you've got to make sure that you have at least 2 millimeters of space here. You have to make sure that the plate has no cracks in it, and you've got to be positioned back towards the lingual. And in many instances, in order to do that, sometimes you have to cup out and remove a little bit of the lingual bone. And if you don't do that, it's gonna, as you go to place that implant in there, that bone is gonna push you towards the bundle. And you don't want that. You've got to make sure that you have this space. So that's why this is going to, bundle bone on the inside is going to resorb away. That's why when I create the osteotomy, I place that grafting material in there, and I take an instrument and I push it back against to fill this space in. Whether or not it's fully filled in or not, I don't think that it matters. I just think that you will, with the grafting material in there, I don't see any soft tissue invasion into that space. Has anyone ever extracted a tooth and it didn't heal up mesially distally? Bone always fills in mesial distally. It won't fill in on the labial, where you can get absorption if you lose the plate through the extraction, or whether or not you have a crack. And one of the risks of immediate placement is if you extract a tooth and you don't take and put your curette in here and palpate and scrape this bone is really, really thin to begin with. Sometimes you can have like a little crack in the plate, and if you've got that little bit of crack in the plate, you'll get some soft tissue invagination, and then you'll get an implant failure. Even if this plate is cracked with immediate placement, as long as the implant is back far enough, and you graft this, you can put some grafting material on the outside and a membrane over the top of it one way. Sometimes you can take it, you can set a little a membrane on the inside of the socket with grafting. There's a lot of different ways, and each situation is kind of unique in itself. So this was a patient that fractured an incisor, broke off, non-restorable. So we wanted to extract the tooth, place our implant. In this particular case, we wanted to give her a temporary so you can walk out with a temporary. So we extract the tooth, and again, I take this gauge and I set it into the apex, and I take that collar and I spin it down until that's where I want my platform. And then I pull it out and I look at it and I go, that platform is the position it would be if I were to put in an 8mm implant. So I make a determination, okay, if that's 8 to the base of the socket and I want 2 to 3 millimeters of apical stabilization, I put in a 12mm implant. So that tells me what length of implant I want to place. With this gauge and spinning that collar down, it's only telling me where my platform's going to be in reference to the tissue. If I want to have the implant deeper, I would have to sink the implant down or drill deeper. So the gauge allows me to make a determination of what implant length I want to place. So if I put in a 12mm implant, my collar, my platform is going to be right here. If I put in a 10mm implant, it's going to be right there, providing I drill 10mm. So it's that reference that allows you to know before you start drilling where your platform's going to be. So before you start drilling, you know where it's going to be at the vertical level you want it, instead of drilling down 10mm, screwing in a 10mm implant, putting it in and go, wait a minute, that's too high. You got to take it out, and then maybe you got to drill deeper and put in a different one. So you don't have to take the implant in and out. So you can just go forth and make your determination and put the implant in. So here's the implant in place the same day. And what we do is, fortunate enough in this particular situation, to put in a solid abutment. So torqued in and screwed in a solid abutment. Then I had these, see the solid abutment, no suture, no flap. This is a thimble of what I call a coping. That coping is made on the implant analogs, so it fits on the implant analogs, and that's made out of polymethyl methacrylate. So this is really, really thin, and it's custom fit, and it fits perfect. It fits like a porcelain waxed crown. It just fits, and it's extremely tight, and it doesn't rotate. So this is placed over the top. After I place that over the top, then I have these, it looks like a veneer. They come in different sizes, and they are, it's a heat processed acrylic. So the only thing I do is I put this on, I mix up a little acrylic, I put it on the inside of this, and I just position it where I want it, tack it to it, let it cure. After it hardens, I take it out, I put it on top of my implant analog, and I just flow resin around that and trim it, and then I put it back in the mouth. So she comes in, and she walks out like this. That's cemented on, and it's cemented on with a cement, and then we clean the cement off. So this would be probably about a month later, healed up. When I talked about, I had gone back in there and I added a little bit of acrylic right here, make sure that I had a contact, because I noticed that that tissue was shrinking a little bit, so I added a little bit of acrylic there to support that papilla. So my implant's in spot, in position, We let it heal up, and in this particular instance, she wanted to go back with an all-ceramic crown because this was an Empress and this was an Empress, so I had a custom abutment made that we screwed in, and then we cemented in an Empress crown. Now, unfortunately, what happened to me, we cemented her crown. She took a bite out of a frozen candy bar, and she fractured that one after I had completed this one. So here we're done. This is before her accident. Now this one is going to break, and when that one breaks, now I'm right back in the same situation again. So now she wants an immediate placement in here, and you can see this is all healed up. Here's our final restoration and custom abutment. Now this one is fractured. Now here, this is a 4.1 implant with a 4.8 platform, but there, no possible way I can put in a 4.1 with a 4.8. So I have to put in a narrow neck implant. Because if I put in a standard size implant, I'm going to encroach on my space that I need, 1.5 millimeters. It's going to cause tissue loss, then I'm going to have an aesthetic problem. So you go through the same process again. And here is my narrow neck implant. This just happens to be a Straumann implant. And here's my final restoration. And it is difficult in between two adjacent implants to have this papilla come down the same length as that. It is really challenging, and it's really difficult. Sometimes it's almost impossible to do. So there's our final restorations there. Do you have any questions? Yes. In retrospect, I would have done that at that point in time. I didn't. That would have been a good idea. But it did act as a support. Yeah, it is. I agree. So when I told you, I showed you that one case that was my first implant, this is the case. Here's the implant, immediate extraction and placement of the implant. So this was day 1. This is day 1095, post placement. Here's another situation of this tooth here does not look too good. And these teeth are not easy to extract either, let alone accustomed. So we decided to extract the tooth. Here's the tooth. We extracted the tooth and placed this in the same day. And this is a Straumann, and they don't make these anymore. This is made out of PEEK material. They don't make it anymore for some reason, and I wish I could get more of them. And I have a large stock of them, and I sterilize them and reuse them. But you can take and shave it down and create your crown, your contours of your crown in that healing cup. So this would be the extraction. This is placed in day 1, and that is your tissue profile 3 months down the road. So you don't have to go through the whole process of tissue modeling and that. You can create your tissue at day 1, and if you look closely at that, even though this is an immediate extraction, you can see where your tissue level is here versus here. Plus, you have all the support. Now, This is very difficult, if not impossible, to use a straight abutment to screw it in because you can't get that deep and clean the tissue, clean the cement off. So here's a custom abutment with opaque on it, and this is an all ceramic crown. So there's the tooth. We extracted the tooth, and I knew that I was going to be doing this, and so I did have a surgical guide made for my reference to know where I am labially. So that's day one. There's the implant in place. This is going to take my impression. This was probably 3 months later, I believe. I left this in 3 months. Take that out, and that's how nice the tissue looks. All by positioning the implant in the proper dimension where it needs to be for healing to occur. So we made the custom abutment to raise the cement line. We took an implant level impression, fabricated that, put the abutment in, torqued it in, cemented the crown. She has some other issues that she needs to be attending to, but she's happy. She wanted a white tooth. She thought, well, eventually I'm going to have these others whitened, so we're going to make this white. So there would be another immediate case where root canals and posts keep a lot of implants in business because they usually fail at some point in time down the road, especially if the posts, when they're made, are not quite long enough or there's not a ferrule. So sometimes, and I've started doing this, instead of extracting the tooth, I just drill right down through the tooth. So if you drill, and I've got a set of drills that I resharpened to do this with, you can drill down the tooth, and the tooth itself will keep you to the lingual. So you drill down through the tooth, and then after you drill down through your tooth, and you just you've already created your axis for your osteotomy, then you go back in and just remove with a approximator, you take and just infracture the tooth. So you can see right here, there's my drill that I went down through the tooth itself. Then after that was done, then I removed the tooth. And it's easy because in this particular case, this tooth had like a little curve to it. And so I wanted to get my implant positioned. It was much easier to do that by leaving the tooth in and then taking the tooth out as opposed to taking the tooth out to begin with. So here's the finished osteotomy after the tooth was removed. And you can see right here's the osteotomy. And you can see here's the inside of the wall. But we're way to the lingual. And again, there's my depth gauge, making my determination. I want to verify everything. And this distance right here, you always want that. You want at least 2 millimeters. Doesn't matter even if it's 3 millimeters. You do not want to have this up. If you have this close to here, you're going to end up with a problem. And then I always do a radiographic verification with my implant in place. And you'll see all of these look the same way. The bevel is just right at the level or slightly below the side level of bone. Sometimes I want to go in and I want to, if I have a high crest, scalp tissue with a high crest, I want to go in and remove a little bit of bone prior to the placement of the implant, just on that buccal and lingual. Or sometimes you have a higher lingual and a lower crest on, you have to remove a little bit of bone on the lingual to get them more in balance. So there's the implant in place. And this particular situation, there was a narrow amount of space, so I had to go with a smaller diameter implant. So this just happens to be a 3.5 millimeter implant. So what I do is, I don't have these peak abutments for this, so there's a temporary titanium abutment. So I take that temporary titanium abutment and I just flow some Licure resin around that. I flow it around there to form what was the old tooth, or the support for the tissue. So you flow that around there, cure it, you can make some adjustments. You put that abutment back in, you torque it in, and then I always go and now I take a little bit of a suture and I just pull this suture up against that. If you can remember, when we go back, we had a large space there. So this healing abutment gives support to that tissue. I don't know if you remember way back when I showed that case that I extracted all the teeth and you put the 4 incisors and we added the extra material on the underside of it to create and form the papilla in the temporary itself. It's that same thought process that allows you to do this in the extraction site. So you need some support for this tissue, and that's what that does. Now, there's another, you could take that and you could do this as a two-stage procedure where you covered it or put like a cytoplasm membrane over the top of it and all that, but then you've got to go back in and you've got another surgical procedure. This way, you don't have near the amount of work. So this is at 1 week. This is particular crown here. She didn't like the color of it. She wanted me to change this crown. So then we made this crown at the same time that we did that. But I mean, just look how nice that tissue looks. And that's just from extraction, immediate placement, support for that tissue, and here is the probably at 10 weeks how nice that healed up. And again, if you were to place in a larger diameter implant, you're not going to maintain this distance. If you don't maintain this distance, you're going to lose bone, you're going to lose tissue, and you're going to end up not having the aesthetic result that you wish. So we made a custom abutment for her, and this is a custom abutment with opaque over the abutment. There's the abutment in place, and again, with the custom abutment, in this particular case, with the proper space in between, you can take these custom abutments and make them the same shape, basically, as the tooth that you're preparing. And that healing abutment that we flowed the composite around and placed in at day 1 started that process that allowed you to do it with a lot less work. And so here's our final result. Are there any questions? This is the implant with a somewhat of like a platform switch to it with the final crown. And this is the case that I showed you the last video of, where we extracted the tooth, placed the implant, there's our final crown. And the video that I showed you, if I were to pull that video back up again, since we did the implant, this crown here we've replaced, and we've replaced this to match all of this. And remember, I said there was that little bit of a space where that triangle had formed. You can see this here we've done, and this we've done. He had really, really short teeth. You could have probably done crown lengthening in the whole process, but he didn't want to go that far with it. But anyway, with this this papilla formed nicely where there was a space there before. So we've already seen the video. So there's another case. This particular this patient is 80 years old, and she has a full upper denture, and she does not want to wear. She had a removable partial at one time. She hates partials. She didn't want to wear it, and so these teeth, these two teeth here, we ended up having to remove. And this on back here is an implant bridge, and this back here is an implant bridge. And the question mark is what are we going to do here if you take you couldn't take just one out because of the amount of bone loss. This is suspect of whether or not you should even take this one out also. And I wanted to take all three of these out, but no, this does not bother me. The only thing I want to do is take these two teeth out here. So we took those teeth out. So this shows the depth gauge in place. This tooth is firm. There's still a large amount of bone in that this tooth is solid. So I could not fit in two implants. So I decided to place one and then make a screw retained crown over the one that would look like two implants. So there's the extraction, the osteotomy here. Back to the lingual. This is giving my reference of where my platform's going to end up. The outside plate was lost a little here, so after we placed the implant in, we grafted all of this. So this shows the implant in place, the graft is there, and here's a membrane, and then all this tissue is pulled back. And then what we did is we took the two teeth that we extracted and cut them off, and then bonded those back in with composite. So that was our temporary. So here are the two teeth that I extracted. I just cut the tips of the roots off, bonded them together, and then bonded them to the length of these adjacent teeth just with composite. And those are the cytoplast sutures that are in place. So when she walked out, that's the way she walked out. Now things are starting to heal up. She could have some better oral hygiene, but you can see in the background there's the platform of the implant. So this just happens to be a 3.5 millimeter implant, and this is the way it looked like in 12 weeks. So it's healing up nicely. There's an occlusal view, and here's my final prosthesis. So this is two with you added a little bit of pink porcelain in there, and then this whole thing is screw retained. Fill that in, and that's her final prosthesis. So she was really happy with that. Now, do we want to take a break now? Okay. I can see some people are falling asleep. So this is an interesting case here that I showed earlier. I'm going to show that whole process.
休息一下，外面有点。